Good evening, everybody. It's my pleasure to welcome you today to this ESOC TV studio on Anticoagulant Reversal Strategies in ICH. It's my pleasure to be here today with Thorsten Steiner, who is a professor of neurology and neurointensive care at the University of Heidelberg and the head of department of neurology at the hospital in Frankfurt-Höchst. My name is David Seiffge. I'm a vascular neurologist and assistant professor at the University of Bern in Switzerland. This slide shows you our disclosures. For today, we have the following learning objectives. We would like that you recognize the risk factors for intracerebral hemorrhage, particularly in patients who are prescribed an oral anticoagulants, and including the importance of a timely diagnosis of the disease and achieving effective hemostasis. We will discuss shortly the current guidelines and how these guidelines are going to evolve in the future, likely going to evolve in the future, and recall you specifically the guidelines on management of anticoagulation-associated ICH. And further, we will discuss the latest trial results exploring effective hemostatic therapies for 10A inhibitor-associated bleedings. So now coming to the management of patients who present with an intracerebral hemorrhage. It's very important to realize that treatment should start timely, but this always starts with first identifying the right patients and then having also a good team. And we will also discuss which role anticoagulation tests play in this context. Thorsten, do you want to say something about current strategies for anticoagulation reversal in patients with ICH? We have three different types of anticoagulants.
Yeah, so nowadays it seems to be that it has become more clear that with the three different types of anticoagulation associated ICH, we also have three different types of treatments. For vitamin K antagonist associated ICH, we use PCCs plus vitamin K in the acute situation. For dabigatran associated bleedings, we use idarucizumab, and I think there is overwhelming evidence that there is no alternative to andexanet alpha. Still, we have to see how we balance risk and benefit, but I think the data are pretty clear.
That's good. I think we have summarized this also on this slide. I think one of the challenges that we sometimes see is that we haven't had trials in the past which provide us good evidence which treatment to choose, but now I think we had latest results that have been presented at the World Stroke Conference, the ANNEXA-I trial, which have been published just yesterday or today, depending in which time zone you live. And I think we also presented further sub-analysis of the ANNEXA-I trial on this conference. So some of you have probably seen my presentation yesterday or Mike Sharma's presentation today. So there's new evidence which was just reported at this conference. I would like to remind you that the ANNEXA-I trial was a randomized controlled trial comparing enrolling patients with an acute ICH within 6 hours of onset and within 15 hours of last intake of factor Xa inhibitor. And the patients were then randomized to receive either andexanet alpha or usual care, with patients in the usual care arm receiving prothrombin complex concentrate in 68% of the cases. The trial was stopped early after interim analysis because it reached this pre-specified endpoint of hemostatic efficacy. And so now I think we have one issue that always comes up in this discussion. It's about restarting anticoagulation after an ICH. Do we have enough evidence that we can restart, when we should restart?
I think there is some evidence that from a couple of trials that shows us that when you not start oral anticoagulation, patients will suffer more from the problem of getting strokes instead of having recurrent ICH. That risk is, the risk of getting a stroke is much higher than having another ICH. And so the recommendation is to, or probably will be to restart oral anticoagulation, and then it's the question when to start. And that's still open. I always say we do not start earlier than 4 weeks, which is pretty early. Others recommend to start 10 weeks after an ICH. I always say the important thing is that blood pressure is under control.
That's good. If we go back in the history now, we have discussed very specific points about treatment and the later phase of the treatment of a patient. But what do you think, Thorsten, what are the most important things that happen when a patient comes into the emergency department? We do a brain scan and we see blood on the scan. What should we do first? What are the first tasks that we should do?
Yeah, we should obviously go for after the question, what is the reason for the bleeding? And we should ask the question, is the patient on an oral anticoagulation? Because if not, or if the probability is low that the patient, you never know, is not on an oral anticoagulant, then the treatment is totally different. Then we are talking about to give whatever. Best is to include somebody in a clinical trial, maybe on tranexamic acid if it is a spontaneous bleeding, or recombinant factor 7. And if it turns out that the patient is on oral anticoagulants, then we have to consider what we were talking when we started. It depends on what drug the patient was on.
So, to your experience or the data, how frequent is this? How many patients are on anticoagulants at the time of bleeding?
At the moment, it is thought to be at least 20% of the patients who are on oral anticoagulants. And the landscape has definitely changed within the last 10 years. 10 years ago, most of the patients were on whatever Coumadin drug. But nowadays, it is more and more oral anticoagulants. And it is even, and there is also a trend, it is more and more factor 10A inhibitors.
So what are the first things that we need to know then, assuming that we have seen a patient now in the emergency department and we see that he has a bleeding in the brain, we know that he's on anticoagulation, so what are the next steps, what we need to do? Do we need to call the hematologist or the neurosurgeon first, or what information do we need now?
Yeah, so first of all is we need to know what the substance was, because I think the most important thing is to stop the bleeding, because you can bring somebody like this in the operation theater, but even then the neurosurgeon will ask for, so what's with the coagulation? So coagulation or hemostasis first, and for that we need to know what drug the patient was on. Do we need a test? There is only one bedside test that's reliable, and that is in case a patient comes in who is on whatever Coumadin, because then we have a coagu check, and that gives us a result within 2 minutes, and we can start treating. This is different for factor 10A inhibitors and for factor 2 inhibitors. There is no real bedside test like testing the INR. For that, you have at least to wait 20 to 40 minutes, depending on the setup of the hospital.
Yeah. Is there any other information that could help us? The last dosage, last intake?
Certainly. That's the next question to the patient, if he or she can answer, or to relatives. Hopefully there.
Which is not the case, actually.
Exactly, is to ask, when was the drug last taken? But then there are these cases where you never got to know. And so you have to make a decision to give a drug, though you do not exactly know when the last dose was taken.
So you were the lead author of the first ESO-ICH guidelines, published roughly 10 years ago. You are now the lead author of the new update of the ICH guidelines. Can you give us a very short summary? What were the recommendations back then in 2014? Where did we include recommendations on factor 10A inhibitor bleedings?
At those times we did not. We did include factor 10A inhibitor bleeding in the 2019 guideline on reversal therapy. And still there is an important change, because at those times we recommended that in case of a factor 10A inhibitor bleeding, you may also consider to use prothrombin complex in case you have nothing available. But there is growing evidence that whether you give or give not PCCs, it doesn't change the game, because PCC is probably not effective.
So at that time point, the guideline recommendation was based on an assumption of an expert opinion,
right.
But there was rather no data to actually support it.
Yeah.
No clinical data, at least.
There were definitely no clinical data. We now have more data from large registries that show us there's probably no effect. The background or reasoning for recommending PCCs was just that there is factor 10A in the PCCs that might have some effect on the bleeding by competing with the bound factor 10, but that was an assumption, and it's probably not true, or it has something to do with just the amount of the factor 10 that is in PCCs.
And so now we are working on the update of the ESO guidelines. It's an exciting time, so many new randomized controlled trials being presented, being positive, which is an additional challenge, I think, for making guideline recommendations. So the guidelines are not yet in a definite version there, but can you probably speculate on will there be a change? I think there will be a change in the recommendations on anticoagulation associated ICH treatment, because we have new data now.
Yeah, I think the story is done concerning vitamin K antagonist associated bleeding. Story is done about what to use when a patient comes in who is on dabigatran and has a bleeding. Question is, how do we handle andexanet alpha? I can foresee that we will probably give a recommendation about the strengths we will see. It all depends on the benefit-risk ratio, and you gave a very nice talk, and perhaps you might tell us a little bit more about your analysis about the importance of thrombotic events versus the hemostatic efficacy.
Yeah, that's a good point. So thank you for highlighting the new data which has been presented at ESOC. So we are right here to discuss it. And as you said, we are confronted in patients with anticoagulation associated ICH. When they treat them, we have two opposing events that may happen. One is the hematoma continues to bleed, so what we call hematoma expansion, and this is what we would like to stop by reversing the anticoagulation, whether it is PCC or vitamin K antagonist, either rituximab for dabigatran or andexanet alpha for 10A inhibitors. But we also always have to fear that we may cause thrombotic events. Early thrombotic events, myocardial infarction, ischemic stroke, later thrombotic events, deep vein thrombosis, pulmonary embolism. And at the moment we were left, the ANNEXA-I trial was designed as a hemostatic efficacy trial because this was the purpose of the drug. It was not designed as an ICH trial having long-term follow-up with functional outcome, which we would expect in an ICH trial. So we are left without substantial information about long-term outcomes. So it was not powered for this answer. So and now we are left with two competing events. One is going up, one is going down. And the question is now for us as clinicians, where's the balance? And the aim of our secondary analysis was to assess the effect of thrombotic events and hematoma expansion on all-cause mortality and on functional outcome at 30 days. So the last follow-up in the ANNEXA-I study was 30-day follow-up with a modified ranking scale score. So we combined both the entire study, so both treatment groups, and what we found was actually that both hematoma expansion but also thrombotic events are significantly associated with 30-day mortality with a 3-fold increase. What we also found is that on top of being associated with mortality, hematoma expansion is also associated with poor functional outcome, defined as a modified ranking scale score of 4 to 6 at day 30. This was not the case for thrombotic events. We didn't find an association here. which is likely, at least in part, also explained by the fact that there were so few thrombotic events in the first day. So for this analysis, it was a landmark analysis, we took all thrombotic events occurring in the first 5 days, so the early events, which were arterial events in the majority of cases, and assessed them, but there were only 13 events in the entire population. So you see how infrequent it actually is. And that's probably, at least in part, to explain why we didn't see an association with outcome. But I think that is also something that we have to have in mind as treating physicians. Hematoma expansion is very frequent. Thrombotic events, although we don't want to have them, fortunately they are rather infrequent. So these were the results of this analysis. And hopefully this will help us to actually then write the guidelines. Yeah,
I think it's a very, very important analysis, because that's what people are asking for at the moment. How do we weigh the risks against each other? And we'll definitely take this into consideration.
So now, assuming the bleeding occurred, we have treated the patient, we have reversed the anticoagulation. Now the next question is, can we restart anticoagulation? When should we restart anticoagulation? We shortly touched upon it earlier in the discussion, but you said you recommend usually 4 weeks, was it right? So what are what is your reasoning behind? Are there any factors which may favor earlier start, or may say you delay the start? Is the MRI important, or the etiology, or what?
Yeah, there are some retrospective analyses that have looked at the curves of embolic risk and of the risk of hematoma reoccurrence. And the interesting thing is that already within the first 2 weeks, you see that the risk for the embolic risk is increasing, while this is only turning up for recurrence of ICH. This is only slowly turning up. And there may be a cutoff point at about 4 weeks. That's one thing. The other thing is when we think about things that are going on, repair mechanisms in the brain, then we thought about that a turning point might be 4 weeks, but this is all of this is plausibility. I think the main point is control of blood pressure. And by the way, I did not mention that this certainly is one thing also already in the acute phase, that if it is not only applying the hemostatic agent, it is even as important to lower the blood pressure as soon as possible. And for that we also have evidence, again evidence from today publication from Interact 4 that showed the earlier you come and lower the blood pressure, the lower is the chance of hematoma expansion. And it had a clinical effect.
Yeah. Exciting times to be in the research in the area of ICH, to see all these positive trials coming and popping up and saying us that we now have an opportunity to treat those patients. So what we had, or what I frequently see in our emergency department, we have an interdisciplinary emergency department, so you have people from internal medicine also running around. ICH patients are mainly treated by neurologists, but we see, but historically we saw a huge nihilism and negative feeling about brain bleeds. As soon as you see one erythrocyte on the MRI or CT scan, everybody was just saying, well, that's it, stop and pray. But there was no conceptualization that there is some kind of active treatment for those patients. But now, since we were doing active treatment for some years, it is not that we suddenly changed all our practice, but it's good to see that we now also see those trials who prove that what we mostly already did, at least in some parts, speaking now for the care bundle and for blood pressure control, makes sense and gives us a push towards active treatment.
Yeah, I mean, if we look for the reason why we did not come up with a guideline during this conference, is that there are 6 randomized trials coming up within the last 4.5 weeks. Yeah, I'm not saying that we will now every 4.5 weeks have another 6 trials.
That would be fantastic.
Yeah, but that's what it is, and the information in there is really, really important. Just to allude to one other thing, when we talk about acute treatment, this brings us to the application of care bundles. And this brings me to another randomized control trial that was published last year, yes, but which is the INTERACT-3 trial. And what that tells us is it combined actually 2 things. One is the acute application of a treatment, but then look for a 7-day of stability. And I think that's very important, that we regard the whole period of things, and I think that makes the difference.
That's important. We slightly skipped because we were discussing restarting anticoagulation, and then we came back to blood pressure, which is very important, and it's good that we discussed it. But I was thinking so there are ongoing trials that actually assess whether restarting anticoagulation in patients with an intracerebral hemorrhage and atrial fibrillation are safe or effective or not. So at the moment, these recommendations are mainly based on retrospective data and cohort studies. There have been 2 small randomized controlled trials, one from the UK and one from the Netherlands, SOSTART and Apache AF. But there are other larger trials like ENRICH-AF ongoing, so which hopefully will tell us one day should we restart and when should we restart. In the meantime, or when we not restart, do you think it would be helpful to have at least aspirin or low dose when the patients are in the hospital, to have a thrombosis prophylaxis, low dose heparin treatment, low molecular weight heparin treatment for thrombosis prevention?
I don't think so, because I mean it really depends on what is the indication for the anticoagulation, and if it is what it is in the most cases, atrial fibrillation, I do not think that there is room for an antiplatelet agent.
So what we do actually, we start as soon as we have a stability scan and showing that the hematoma is stable after 24 hours, we very early introduce at least low molecular weight heparin for thrombosis prophylaxis. I think that is something we should have in mind, and specifically in the patient population which is at risk of having thrombotic events. It should have that in mind. Yeah,
that's certainly something there is, which is also will be part of the recommendations. So we are talking about prevention of acute complications, DVT. There is some evidence that probably the application of intermittent numeric devices is at least as effective as low molecular weight heparin. In our hospital, we use IPCs, the intermittent numeric devices, for 3 days, and then we switch to low molecular weight.
Because then you would like to start rehabilitation one day for the patient, and it's quite inconvenient with these devices to walk around. At one day you have to switch, I think.
Yeah, and the evidence is more on the side of the IPC in the acute phase than it is low molecular weight.
What we do actually, because you said for patients with atrial fibrillation, antiplatelet therapy, not sure. I think what we do in clinical practice for our patients is that before we consider whether we restart or not anticoagulation in those patients, at least as a bridging, if we foreseen that the patient will not restart anticoagulation for the next weeks or months, we start at least aspirin, which had at least historically a 30% risk reduction in AFib. It's not as good as our anticoagulation, I totally agree, but I think it's at least better than doing nothing. With the aim then to come to our anticoagulation one day. Whether this is really safe or whether I think it should be safe. We had the data from Restart that antiplatelets are not very likely not causing recurrent bleeding or increasing the risk of recurrent bleeding in those patients, and
reducing ischemic events.
Ischemic events, yeah.
That is
thinking of myocardial infarction.
Yeah.
So I think this is at least something that we do in our clinical practice. If it is foreseen that the patient is not going to be restarted later. Do you think there's a role for left atrial appendix occlusion in those patients?
Definitely is. There is. I'm thinking of there is not a randomized controlled trial. Please correct me if I'm wrong, but there are good clinical data for the application of an LAA occluder. We are doing that, for example, in patients where we see a definite need for anticoagulation, but we cannot do it because they have, let's say, the second bleeding. In those cases, we always recommend LAA occluder.
That's good. And at least in Germany, there's no reimbursement issues for this indication. I think in most countries, for this indication, there seems to be a good reimbursement situation. So before we finish, I think we have discussed the results that have been presented at this conference. So we have discussed INTERACT-4, you discussed it. You discussed my analysis of the ANNEXA-I trial. Was there anything else in the conference that grabbed your interest?
Certainly the surgical trials, which is not the topic today, but this is, I mean, looking at the effect size of these treatments, that is really something, and we will have to go into our analyses now and see what's coming out. It looks like for minimally invasive surgery that there is a room to add this to, at least in parts, to the routine of patients with lower ICH. For decompressive surgery, in times where we do not have anything else to offer for these patients with larger bleedings, because we are talking, when we are talking surgery, we are talking about larger bleedings. Decompressive surgery is certainly something we need to consider in the future.
Yeah. Okay. So I think that's a good closing word, because this was a Swiss trial and we're in Switzerland. So the Swiss trial on decompressive surgery, SWITCH, was also presented. And I think I learned a lot. Thank you very much, Thorsten. Thank you very much for listening or watching, and enjoy the conference.